Now we have Dr. Mahesh Gopalakrishnan talking on post-injection and post-vitrectomy endophthalmitis. Incidentally, Mahesh Gopalakrishnan is the president of KSOS and he heads the vitreoretinal department at Giridhara Institute, Cochin. Over to you, Mahesh.
Thank you, Meena madam and Thomas. So I will be talking on post-injection and little on post-vitrectomy and endophthalmitis because many of you may not be doing vitrectomy. But post-injection and endophthalmitis is on the rise because a lot of people are using injection in many indications. So I will go to that. This was a case of 64-year-old gentleman, local Panchayat president, who had defective vision in left eye, hypertensive. It was a BRVO, nothing great in the diagnosis. It's a BRVO, and the macular edema was there. So I injected. That time it was, I think, 13 years back. That time there was only 2 drugs. I injected Avastin. So after Avastin, 4 days later, he presented with severe vision loss. And this was the picture. It's very hazy. Disc can be just made out. Anti-segment cells are there, but no gross hypopion. AT is normal, fundus is. So I injected immediately Vanco and Cefta, and AC tap, and I think Vitreous tap was also taken. KOH, bacterial and fungal culture all done, negative. It improved gradually, and after 1 month, with one injection, because it was an early intervention, 4th day, it improved gradually, and after 2 months, this is the thing. In fact, that was a cluster of 6 cases which came over 5 days. This was taken, we allocate it into different vials and then use it, pack it in EO sterilized pouches, and we use it continuously. It was 6 cases, along with others who 11 cases did not have any problem. So culture of vitrectomy cases showed staph epidermidis. This was the organism. And this other cases, first case presented on 8th day. That is very important. If the patient comes a little late, it will finally end up with vitrectomy and intravitreal antibiotic. Very early presentation, 5th day, intravitreal antibiotic may be enough. And so all the cases were managed. We could save all the cases with many of them having good vision. So there are some learnings in this case. One is, unlike post-cataract surgery endophthalmitis, the inoculum that you inject inside is very less. Post-cataract surgery endophthalmitis may be from the instrument or from the fluid. So you inject a lot of organisms into the eye and it will be very severe. Number 2 is, it is mainly posterior segment manifestation, not anterior segment like a cataract surgery, where you will get a lot of hyperpain, corneal edema, secondary glaucoma, like that. So here they present with increase in floaters and blurring of vision first, and not like pain and corneal edema and IOP rise. So immediate management yields good result. So that is main thing. If you wait for 1 week, or 2 days, 3 days, 4 days, it will end up with vitrectomy. Otherwise, it can, many of them are low virulent organisms, and you can save the eye with injections only. And this is important in another aspect. Many of us see the patient after injection next day. Most probably the next day there won't be any issue because the inoculum is very small. Patient may not have proper endophthalmitis signs. Usually it comes after 4 or 5 days. So you have to teach the patient that if suddenly floaters are increasing and blurring of vision is there, they have to report, and listen to the patient. When they call in the phone, ask them to come immediately. So these are some of the things, and as I always say, medical legal implications are there in using Avastin today. There are cases, the court has said clearly that the off-label medicines are not for use. There are multiple verdicts now. 10 years back, this was not the issue because there were a lot of options. There was no options other than this and one expensive option. Now there are a lot of biosimilars approved for this medicine. So it will be difficult for you to defend in the court of law to defend Avastin endophthalmitis. Okay, number 2, this was a case. This is not a endophthalmitis due to the injection. This is a missed diagnosis. So there was small hemorrhage in the macula. Vision was 6/45, and you can see shrum-like picture, pre-RP hyperreflective complex in the OCT below, and it was injected. 1 week after Avastin injection, patient came like this with an abscess in the macula. So what was it? We were shocked actually to see this. There was a choroidal thickness and plenty of vitreous cells. and the chemosis, vitritis. Patient gave a history of TB in multi-drug resistant TB many years back, for which he was treated partially and all. So we did every investigation and exciton was done, and it found that mycobacterium tuberculosis. So it was a tubercular abscess which we, in this early stage, we thought it was a CNVM, and we injected. That was actually not a, the injection has not done any damage, but it was a misdiagnosis. So this is another point that I want to highlight. Look at the biomarkers very carefully and then only inject. This lot of general comprehensive ophthalmologists are injecting without an indication. I had a CSR patient injected with a biosimilar, and patient went into endophthalmitis and panophthalmitis, and this was phthisis, and that was a 40-year-old person. So just imagine, these are all difficult to defend, the mistakes that you should never have. So ultimately this became a painless phthisis, and later patient also died due to systemic TB. So that is, so don't jump into injections, look for atypical findings, multimodal imaging. So don't think that injections are very, very, it's medical retina is becoming booming in India with a lot of injection companies approaching general ophthalmologists to give injection for anything. Okay. Now the second part of the talk is endophthalmitis after vitreous surgery. It is an uncommon finding, but it's a devastating complication. In 25 years in Cochin, we had 3 cases of endophthalmitis after vitrectomy. All of them we lost. So there are different studies reported incidence of 0.05 to 0.2% across the world. When MIVS started, initially there were reports that MIVS causes more endophthalmitis because the tunnels are not sealed properly. So there were some studies. Vivek Dave and all published in 2014 endophthalmitis following pars plana vitrectomy, a multi-center study, and they found that inadequate wound closure, hypotony, vitreous incarceration, and all these things, including diabetes and trauma, they all were the predisposing factors in post-vitrectomy endophthalmitis. There was a large study by Shankar Nethralaya of 1,11,000 cases, of which 70,000 plus was 20G and later all MIVS. And they found that the incidence is around 2 per 10,000 surgeries, and there are some risk factors in 20 gauge. Actually the number of cases in 20 gauge was more than in MIVS in their cohort, and this was statistically significant. Probably they included all the cases of 1990s and 2000. So, and here also the presentation will be little different. Unlike post-cataract surgery endophthalmitis, the anterior segment findings are will be significant, but the intraocular pressure and the vitritis will be more in post-vitrectomy endophthalmitis. The potential predisposing factors in the study was diabetes, vitrectomy for vascular retinopathies, vitrectomy, combined surgery, that is another cataract with vitrectomy. So the risk factor totally changes in combined surgery. Culture proven cases were 53% overall, and most common organism was Pseudomonas Pseudomonas. And in culture negative had better outcome than culture positive. Probably because culture positive means there was a lot of inoculum and we are getting culture positive because of that. So that is regarding culture. In their study they said that MIVS does not increase the risk of endophthalmitis. So that was the conclusion from that. Now in the last part is endophthalmitis in silicone oil filled eye. It's a very tricky thing because the inoculum is very, very small, and silicone oil has anti-infective property, and presentation will be like vasculitis and vascular occlusion along with anterior segment findings. So we give half dose intra-oil antibiotic injections, and silicone oil removal with antibiotic wash and re-silicone oil injections are tried. These are all rare things that you may not come across very. Another factors that affect post-vitrectomy endophthalmitis, whether you have put gas, whether you have put silicone oil, And vitrectomy alone, they have a usually violent course. Immediately they will have panophthalmitis with choroidal detachment and other problems. A delay in intervention, if the choroidals develop, it will be very difficult. You can't go inside and do any surgery. So these are some of the. So post-vitrectomy endophthalmitis is a rare but devastating complication, and immediate intervention may save some cases even though prognosis is bad. Thank you.